Welcome, curious minds, and especially welcome to you, our nursing students.
Yeah.
Today, we're doing a really crucial deep dive.
Yep, specifically for you, we've got some key sources on pregnancy complications.
Right, and the mission is pretty straightforward. Pull out the must-know info you'll need, right on the front lines.
Exactly. We want to break down these sometimes really complex medical ideas into something clear, actionable.
Actionable insights, I like that.
Yeah, focusing on the why, the pathophysiology, and then those signs and symptoms you just can't miss. Plus the nursing care, the interventions, and of course the key medications, stuff you'll use every day.
So think of it like your clinical prep shortcut for some tough OB situations. Sound good?
Let's do it.
Okay, let's unpack this. All right, imagine this. You're in OB triage. Maybe it's your first placement. Patient comes in, first trimester, some bleeding. What's going through your head?
Right. Is this, something relatively minor, or is it one of the big hemorrhagic conditions of early pregnancy?
Exactly.
Yeah.
So let's start there. Abortion, the different types, and ectopic pregnancy.
Good starting point. Understanding these is, well, it's foundational. You absolutely need to be able to differentiate them and know your immediate priorities.
Okay.
So we'll hit the pathophysiology, how they look clinically, the manifestations, and what you do as the nurse. So first, let's clarify abortion in the medical sense. We mean pregnancy termination before 20 weeks, or if the fetus is under 500 grams.
Right, not necessarily elective, could be spontaneous, what most people call miscarriage.
Exactly. Spontaneous abortions can happen for lots of reasons: genetic problems, hormone imbalances, maybe issues with the uterus itself. But for you, the nurse on the floor, the immediate thing is figuring out what kind of abortion it is, because that changes everything.
Okay, so it's not just one thing, it's a spectrum. And you mentioned the cervix is important.
Spot on. It is a spectrum, and yeah, the cervix tells you a lot. So first up is a threatened abortion. You've got vaginal bleeding, but crucially, the cervix is closed. No dilation, no effacement, no tissue passed.
So there's still a chance the pregnancy could continue.
There is. It's a warning sign. Then you have an inevitable abortion. Here, the bleeding continues, maybe heavier, and the cervix is dilated. Often the membranes have ruptured too. At this point, the pregnancy loss is unavoidable.
Okay, inevitable. And what if only some tissue comes out? That sounds risky.
Very risky. That's an incomplete abortion. Some products of conception are expelled, but not all. The big worry here, hemorrhage. You'll often see heavy bleeding and severe cramping because the uterus is trying to expel what's left.
So heavy bleeding, cramping, partially passed tissue, red flag for incomplete.
Big red flag. Then there's missed abortion. This is when the fetus unfortunately dies, but stays in the uterus for days, maybe weeks. Symptoms might be subtle, maybe just some brownish discharge or pregnancy symptoms fading.
That sounds emotionally difficult too.
Extremely. And finally, there's recurrent spontaneous abortion that's defined as 3 or more consecutive losses. That signals a need for a deeper workup to find an underlying cause.
Okay, so across this spectrum, what are the core signs and symptoms you're assessing for, and what are the immediate nursing actions?
Key signs are vaginal bleeding, could be spotting, could be a hemorrhage, cramping, maybe backache, pelvic pressure. If it's incomplete, you might actually see tissue.
Right.
Your nursing assessment. Vitals. Vitals. Especially watching for shock tachycardia, hypotension, how much bleeding, what color, pain level. And honestly, just as important is emotional support. This is often devastating for patients.
Absolutely. And interventions. What medications should we have on our radar?
Interventions often involve getting IV access ready for fluids, maybe blood products if bleeding is bad. Prepare them for possible procedures like a DNC dilation and curettage, or a D&E dilation and evacuation, to remove any remaining tissue.
Okay.
Medication-wise, methylorgonavine, brand name Methergine, might be used for incomplete abortion. It makes the uterus contract really strongly to control bleeding and expel tissue.
Got it. Methergine for uterine contraction.
Yep. And misoprostol, or Cytotec, that's a prostaglandin. It's also used to help expel retained tissue in missed or incomplete abortions, kind of softens the cervix and causes contractions.
Misoprostol, okay.
And always anticipate the need for blood transfusion if the hemorrhage is significant. Be ready for that possibility.
Okay, so that covers the spectrum of abortion. But what about when the pregnancy implants somewhere it shouldn't? That brings us to ectopic pregnancy. This sounds particularly dangerous.
It is extremely dangerous. Ectopic means the fertilized egg implants outside the uterus. Most commonly, like over 90% of the time, it's in a fallopian tube.
Fallopian tube, okay.
Could be the ampulla, isthmus, fimbria, even the interstitial part where the tube joins the uterus. But wherever it is outside the uterus, it can't grow properly. The tissue isn't designed for it.
And the danger is rupture, right?
Exactly. As it grows, it stretches the tube and eventually it can rupture. That leads to massive internal bleeding into the abdomen, a true surgical emergency.
So what are the absolute must-know signs for ectopic that you need to be watching for, especially given that internal bleeding risk?
The classic triad is 1, a missed period, 2, abdominal or pelvic pain, usually unilateral, just on one side, often sharp, can be quite severe, and 3, vaginal spotting or bleeding.
Missed period, unilateral pain, spotting. Got it.
But here's a really key sign, sometimes missed. Shoulder tip pain.
Shoulder pain. How does that happen?
It's referred pain. If there's internal bleeding, the blood can irritate the diaphragm, and the phrenic nerve sends pain signals up to the shoulder. So, unilateral pelvic pain plus shoulder pain. Think ectopic until proven otherwise.
Wow, okay. Good tip.
And as it progresses, if rupture occurs, you'll see signs of hypovolemic shock, fast heart rate, low blood pressure, pale, clammy skin. That's a code situation.
So if you suspect ectopic, what are your nursing priorities? What do you do immediately?
Assess. Look for that triad. Ask about shoulder pain. Monitor vital signs constantly for any hint of shock. And again, emotional support is huge.
Right.
Interventions-wise, you're preparing for likely surgery, usually a laparoscopy. They might do a salpingectomy, remove the affected tube, or maybe a salpingostomy where they make an incision in the tube, remove the ectopic, and try to save the tube.
Okay. Surgery is common. Is there ever a non-surgical option?
Yes. Sometimes. If the ectopic is unruptured, the patient is stable, and it meets certain size criteria, medical management is an option.
And what medication is used for that? And what are the really important things you need to teach the patient?
The medication is methotrexate. It's actually a chemotherapy drug, but in lower doses, it stops rapidly dividing cells, like those in an ectopic pregnancy, from growing.
Methotrexate. Got it.
So it dissolves the pregnancy, but patient education is critical. They need to know about side effects like nausea, vomiting, mouth sores, stomatitis. And crucially, they must avoid folic acid supplements, alcohol, and NSAIDs like ibuprofen, because those interfere with how methotrexate works or can worsen side effects. They'll need follow-up blood tests, checking HCG levels to make sure the pregnancy is resolving. Sometimes more than one dose is needed.
Okay, we've navigated those really tricky early pregnancy bleeds. But the landscape changes as pregnancy progresses, doesn't it?
Mm-hmm.
Let's shift gears to late pregnancy hemorrhage, placenta previa and abruptio placentae.
Yes, these are the two big ones later on. And differentiating them quickly is absolutely vital because they present differently and pose immediate threats to both mom and baby. Nursing vigilance here is just non-negotiable. Let's tackle placenta previa first. Pathophysiology-wise, this is pretty straightforward. The placenta implants low in the uterus, so low that it partially or completely covers the cervix, the opening the baby needs to come through.
So it's physically blocking the exit, and the classic sign is the telltale differentiator.
Exactly. The hallmark of placenta previa is painless, bright red vaginal bleeding, usually showing up in the second or third trimester.
Painless and bright red.
Okay. It can be spotting, it can be intermittent, or it can be a sudden massive hemorrhage. But typically no pain associated with the bleeding itself because the uterus isn't contracting or tearing away from the placenta initially.
Makes sense. So nursing care, what are the absolute do's and don'ts?
Do assess the bleeding amount, color, monitor mom's vitals closely for shock, continuous fetal monitoring, check that heart rate and variability, get good 5V access, maybe 2 large bore IVs, keep the patient on bed rest. Prepare for a likely C-section, especially if bleeding is heavy or the baby's in distress.
And the absolute don't.
The absolute critical don't is no vaginal exams, ever. If that placenta is overlying the cervix, putting fingers or anything up there could puncture it or cause massive separation and catastrophic bleeding. So no vaginal exams until previa is ruled out by ultrasound.
Okay, painless, bright red bleeding, previa, no vaginal exams. Got it. But what if the picture is totally different? What if it's sudden, agonizing pain, a rock-hard belly, and maybe dark red bleeding?
Now you're describing the classic presentation of abruptio placentae, or placental abruption. Much different, much scarier sometimes.
So how does that happen? What's the pathophysiology there?
Abruption is when a normally implanted placenta starts to detach from the uterine wall before the baby is born. This separation causes bleeding between the placenta and the uterus, forming a hematoma.
It will bleed behind the placenta.
Right, and that has 2 major consequences. One, the mother can bleed heavily, sometimes internally if the blood is trapped. That's called a concealed abruption. Two, the area of detachment can no longer exchange oxygen and nutrients, so the baby's oxygen supply is compromised, often severely.
That sounds critical, so the signs reflect that detachment and bleeding.
Exactly. You get sudden onset of severe abdominal pain, often constant pain. Uterine tenderness, it hurts when you touch the abdomen. And that classic rigid, board-like abdomen, because the uterus is filling with blood and becomes hypertonic, just clamps down hard.
Rigid, board-like.
Okay. The vaginal bleeding is often dark red, old blood, though it might be absent if it's concealed. Mom often shows signs of shock, sometimes out of proportion to visible bleeding. And the baby. Fetal distress is very common, bradycardia, loss of variability, late decelerations on the monitor.
So the intense pain and that rigid uterus are key differences from Previa. Nursing priorities here must be immediate, right?
Absolutely immediate. Monitor mom for shock again. 2 large bore IVs for rapid fluids and potential blood products. Continuous fetal monitoring is essential. Assess the bleeding amount and character. Be aware of potential coagulation problems. Abruption is a major risk factor for DIC.
DIC.
Disseminated intravascular coagulation, we should touch on that. But the main intervention for abruption, prepare for immediate delivery, usually an emergency C-section if the baby is still alive and in distress, or sometimes vaginal if delivery is imminent and mom is stable. You have to get the baby out and stop the bleeding. And yeah, that brings us neatly to disseminated intravascular coagulation, or DIC. It's a potential, often lethal, complication of things like severe abruption or severe preeclampsia.
DIC always sounds so paradoxical, like the body is clotting and bleeding at the same time. Can you break that down?
It is paradoxical, and that's what makes it tricky. Basically, something triggers massive, widespread activation of the clotting system. Tiny clots start forming everywhere, in small blood vessels.
Okay, lots of little clots.
Right, but here's the twist. Forming all those clots uses up your clotting factors and platelets incredibly fast. You run out of the stuff you need to form normal clots where you actually need them.
So you deplete your resources.
That's exactly. So you end up with this bizarre situation of microclots blocking blood flow in some areas, while also having widespread, uncontrolled bleeding from other sites because you have no clotting factors left.
So what does that look like clinically? What are the signs you'd see, and what's the nursing approach?
You'll see bleeding from places that don't normally bleed much, IV sites, gums, nosebleeds, maybe blood in the urine or stool. You might see petechiae, those little pinpoint red spots, or purpura, larger bruises, and signs of shock, of course. Nursing care involves super close monitoring of all bleeding sites, vital signs, and labs platelets, fibrinogen levels, PT, PTT. The most important intervention is to treat the underlying cause. If it's abruption, deliver the baby and placenta. If it's sepsis, treat the infection.
Then dress the trigger.
Yes, and then you support them by replacing what they've lost, administering blood products like platelets, fresh frozen plasma, FFP, which has clotting factors, and cryoprecipitate, which is rich in fibrinogen.
Right. Shifting from bleeding to another major category, hypertensive disorders. Preeclampsia and eclampsia. These seem like they can sneak up on you but affect everything.
They really can. And for you as nursing students, understanding how this whole process of systemic vasoconstriction, blood vessels clamping down everywhere, impacts all the organ systems is key. It guides your entire assessment. So preeclampsia, it's a multi-system disorder. The underlying issue seems to be related to the placenta, causing widespread vasospasm, narrowing of blood vessels, and endothelial dysfunction. That means the lining of the blood vessels gets damaged and leaky.
Leaky vessels. What does that lead to?
Well, fluid leaks out of the bloodstream into the tissues, causing edema. It also means less fluid volume in the vessels, which can paradoxically lead to hemoconcentration, making the blood thicker, and reduced blood flow to vital organs like the kidneys, liver, brain, and the placenta itself.
So it's not just high blood pressure, it's impacting perfusion everywhere.
Precisely, which explains the range of symptoms.
And what are those key signs and symptoms beyond just the BP reading?
The definition starts with hypertension, BP 140/90 or higher after 20 weeks plus proteinuria, usually 0.3 grams or more in a 24-hour urine collection, or a dipstick reading of 1+ or more.
Okay, BP and protein.
But you need to look for more. Edema, especially if it's sudden onset in the face or hands. Persistent headache that doesn't go away with usual remedies. Visual disturbances, blurred vision, seeing spots or floaters. Epigastric pain or right upper quadrant pain that often indicates liver involvement. And hyperreflexia, exaggerated deep tendon reflexes, maybe even clonus, which is that rhythmic tapping of the foot when you dorsiflex it.
Clonus, okay. Need to check those reflexes.
Definitely. And severe preeclampsia ramps everything up. BP 1601, 10 or higher, severe headache, persistent visual changes, maybe pulmonary edema, elevated liver enzymes showing liver damage, low platelets, or signs the kidneys aren't working well, like high creatinine.
That sounds like a really intensive assessment needed. What are the core nursing interventions?
Frequent BP monitoring is key. Daily weights to track fluid retention, strict INOs, assessing those deep tendon reflexes regularly, asking about subjective symptoms. Do you have a headache? Any vision changes? Any pain here? Pointing to the epigastric area. Monitoring labs closely, urine protein, liver function tests, platelets, creatinine.
Okay.
Interventions often include bed rest, usually in a quiet, low-stimulation environment to reduce CNS irritability. Seizure precautions are essential: padded side rails, suction available, and ultimately preparing for delivery, because removing the placenta is the only real cure.
Now, the big medication here is magnesium sulfate, right?
Yeah.
What's its main job, and what are the critical safety checks for nurses?
Yes, magnesium sulfate is the go-to drug. Its primary purpose is to prevent or treat eclamptic seizures. It works as a CNS depressant. It does cause some vasodilation, which might lower BP slightly, but that's not its main job. It's for seizure prevention.
Seizure prevention, not BP control, primarily. Got it.
And because it's a CNS depressant, you must monitor for toxicity. Key signs are loss of deep tendon reflexes, respiratory depression, respiratory rate less than 12, blurred vision, slurred speech, muscle weakness, and decreased urine output, less than 30 milliliter.
Okay, loss of reflexes, slow breathing, low urine output danger signs.
Exactly. And you need to have the antidote readily available, calcium gluconate. If toxicity occurs, you stop the magnesium and administer calcium gluconate intravenously.
Calcium gluconate for magnesium toxicity. Check. What about the actual blood pressure meds?
Right, we often need antihypertensives too. For acute severe hypertension, like that 160 110 range, common IV meds are labetalol, which is a beta blocker, and hydralazine, a vasodilator. For more sustained control, nimodipine, a calcium channel blocker, often given orally, is used. And for chronic hypertension during pregnancy, methyldopa is a common choice.
Labetalol, hydralazine, mifepristone, methyldopa.
Okay. And one more, sometimes low-dose aspirin is started early in pregnancy for women at high risk of developing preeclampsia as a preventative measure.
So if preeclampsia progresses despite management or isn't caught in time, it can lead to eclampsia. That means seizures, right?
Yes. Eclampsia is defined as the onset of new generalized seizures, typically tonic-clonic grand mal seizures, in a woman who already has preeclampsia.
What does that look like, and what's the immediate nursing action?
It looks like a typical grand mal seizure, usually preceded by worsening symptoms like severe headache, visual disturbances, or hyperreflexia. During the seizure, your absolute priorities are patient safety and airway. Turn her on her side if possible, protect her head, don't restrain her forcefully, don't put anything in her mouth. Ensure the airway is clear afterwards. Monitor vitals and fetal heart rate closely.
Safety and airway first. Then what?
Administer magnesium sulfate bolus and start an infusion if she's not already on it. It's the primary treatment. If seizures continue despite magnesium, drugs like diazepam, Valium, or lorazepam, Ativam might be given. Rarely, phenytoin is used. And once she's stabilized, the plan is usually expedited delivery. And sometimes, intertwined with severe preeclampsia, you see HELLP syndrome. It's an acronym.
Right, HELLP. Hemolysis, elevated liver enzymes, low platelets. Sounds serious.
It is very serious. It's considered a severe variant or complication of preeclampsia, though sometimes it occurs on its own. Hemolysis means red blood cells are breaking down. Elevated liver enzymes indicate liver damage. Low platelets mean impaired clotting.
Are the signs obvious?
Not always initially. Symptoms can be vague malaise, feeling generally unwell, fatigue, nausea, vomiting. Right upper quadrant pain is a big clue indicating liver swelling, headache, sometimes jaundice. Because it can progress rapidly and has serious consequences, quick recognition and management are crucial. This often involves stabilizing the mother, potentially transfusing blood products like platelets, and prompt delivery is almost always necessary.
Okay, let's shift gears one more time to cover some metabolic and immunologic challenges, starting with diabetes in pregnancy.
Yeah, diabetes, whether it's pre-existing or develops during pregnancy, gestational diabetes requires really careful management. It significantly impacts both the mother and the developing baby. It's like walking a tightrope trying to keep blood sugars in range. So you've got two main types here: pre-existing diabetes type 1 or type 2 that the woman had before getting pregnant, and then gestational diabetes mellitus, or GDM.
GDM is the one that develops during pregnancy.
Exactly. It's glucose intolerance that starts or is first recognized during pregnancy. What happens is placental hormones, like human placental lactogen, increase insulin resistance. In some women, their pancreas can't produce enough extra insulin to overcome this resistance, and their blood sugar levels rise.
So the placenta itself makes it harder for the insulin to work.
Pretty much, yeah.
What are the risks if diabetes isn't well controlled during pregnancy? For mom and for baby.
If blood sugars are high, you might see the classic signs: polyuria, keying a lot, polydipsia, thirsty, polyphagia, hungry. For mom, risks include developing preeclampsia, higher chances of infections like UTIs, hydramnios, too much amniotic fluid, and preterm birth.
Okay. And for the baby.
For the baby, high maternal glucose crosses the placenta. The baby's pancreas makes extra insulin to handle it. This excess insulin acts like a growth hormone, leading to macrosomia, a really large baby, which increases risk of birth injury. After birth, the baby's glucose supply from mom is cut off, but the pancreas is still pumping out extra insulin so they can become severely hypoglycemic. With pre-existing diabetes, especially if poorly controlled early on, there's also a higher risk of congenital anomalies.
Wow, lots of potential issues. So nursing care must focus heavily on glucose control and monitoring.
Absolutely. Frequent blood glucose monitoring is central fasting, before meals, after meals. Sometimes A1C levels are tracked. Urine testing for ketones or glucose might be done. Lots of fetal surveillance, too. Ultrasounds to watch growth, non-stress tests for well-being.
And interventions. What are you teaching the patient?
A huge part is education. Nutritional counseling is key diet changes, carbohydrate counting, encouraging appropriate exercise, teaching them how to monitor their own blood glucose, and if needed, how to administer insulin. Insulin is the primary medication for both GDM and pre-existing diabetes in pregnancy.
What kinds of insulin? Are there oral options too?
Various types of insulin are used, often in combination, tailored to the individual. Things like regular NPH, other intermediate-acting insulins, rapid-acting like Lispro or Espart, and long-acting like Glargine or Detamir. The goal is to mimic normal insulin patterns.
Okay, lots of insulin options. What about pills?
Oral agents like metformin and glyburide are sometimes used for GDM, but insulin is generally preferred because it doesn't cross the placenta as readily, and we have more data on its long-term safety in pregnancy.
Okay, last reader topic for today. RH incompatibility. This is an immunologic one, where the mother's body can react against the baby's blood.
That's right. It's a fascinating and potentially dangerous immune response. It happens when an Rh-negative mother carries an Rh-positive fetus.
RH-negative mom, RH-positive baby.
Correct. If some of the baby's Rh-positive red blood cells get into the mother's circulation, which often happens during delivery, but can also occur with miscarriage, abortion, trauma, or procedures like amniocentesis, her immune system sees the Rhd antigen on the baby cells as foreign.
And makes antibodies against it.
Exactly. She becomes sensitized, producing anti-Rhd antibodies. Usually, this first Rh-positive baby isn't affected much, but the problem arises in subsequent pregnancies with another Rh-positive fetus.
Ah, the antibodies are already there waiting.
Precisely. Those maternal antibodies can cross the placenta and attack the new fetus's Rh-positive red blood cells. This causes hemolysis breakdown of red blood cells, leading to fetal anemia, jaundice, and in severe cases, hydrops fetalis, which involves massive edema, heart failure, and can be fatal.
So the mom herself doesn't feel sick, but the baby is at risk.
Mhm.
What's the key nursing role here? Prevention, mostly.
Prevention is absolutely key. We screen all pregnant women for their blood type and Rh factor, and also do an antibody screen called an indirect Coombs test to see if they're already sensitized.
Okay, screening first.
If a woman is Rh negative and not sensitized, the main intervention is administering Rh0D immune globulin. You probably know it by the brand name Rogam.
Rogam. When is that given?
It's given routinely to Rh-negative unsensitized mothers around 28 weeks gestation. Think of it like it mops up any fetal Rh-positive cells that might have crossed over, preventing the mother's immune system from reacting.
So around 28 weeks.
Yes, and then again within 72 hours after delivery if the baby is confirmed to be Rh-positive.
Okay, after birth too, if the baby's positive.
And critically, Rogam should also be given to an Rh-negative woman after any potential sensitizing event, miscarriage, abortion, ectopic pregnancy treatment, amniocentesis, chorionic villus sampling, or significant abdominal trauma during pregnancy. This prevents her from developing those antibodies that could harm future Rh-positive babies. Wow, we've covered a lot. From early bleeds to late bleeds, hypertension, DIC, diabetes, Rh issues. It really underscores how complex pregnancy can be and how vital the nurse's role is.
It absolutely does. It's about that constant vigilance, isn't it?
Mhm.
Understanding the why behind the symptoms, the pathophysiology, and then knowing exactly what to do, how to use those nursing interventions and medications effectively. Every detail really counts.
And don't forget the human element. Your
Yeah.
assessment skills, your knowledge of meds, they're critical. But your compassionate support for that patient and her family who are likely scared and overwhelmed, that's just as vital. You're often their anchor in a storm.
Such a good point. So, for all of you listening, our future nurses, here's something to think about. How does understanding the connections between these conditions, like how severe preeclampsia can trigger HELLP, or how abruption can lead to DIC, how does seeing that bigger picture help you anticipate problems before they fully blow up?
Yeah, how can you use that knowledge to advocate better, to intervene earlier, maybe even when the signs are still subtle?
It's about connecting those dots, seeing the whole patient, the whole picture. That's where truly excellent nursing happens.
Well said.
Okay, that's it for this deep dive. Stay curious, keep asking why, keep learning, and we'll catch you next time.